All right. Hello, everyone. Welcome to the first live stream of the Unhealthy Policy Podcast. I'm here with David. How you feeling today?
Pretty good, Jake. Worked last night. Excited to have one or two people following along while we stream this, and hopefully they don't see the bags under my eyes.
Did you send it to your mom? Because I feel like she's our number one listener.
She's actually off, looking at giraffes in Africa or something. So she's not on there. Somebody else, if there's a listener.
Awesome. So, as people probably are aware, if you're tuning into this is day two of the ACIP meeting. It started like 4 or 5 hours ago, but David and I are pretty patient, but we didn't have patience to watch all 8 hours of it. So we're going to kind of watch some things that have already happened, and then we'll kind of catch up to the voting and go from there. But kind of, David, what's at stake today?
It's a good question. The one that I don't exactly have an answer to because it's hard to know what's going on. There have been a lot of changes recently, but the ACIP meeting generally is one that's put on where a national advisory board will vote on vaccine recommendations, kind of evolving or new vaccine recommendations that then go to the CDC for approval. And those recommendations are important because they help not only doctors determine when to provide vaccines and on what schedule, but also they help the payers understand what vaccines to pay for and when. And so it's a highly impactful meeting that has the potential to really affect millions of people around the country.
Yeah, and David, I think there's been a lot of turmoil in the CDC in recent weeks. The CDC interim director, who was only there for a month, kind of quit or got fired, and then a bunch of the kind of top senior leadership also quit. And the CDC director was testified before Congress and basically said the reason that she was fired is that she didn't agree to automatically accept the ACIP recommendations. She wasn't going to rubber stamp them. So I think that's kind of the context that this is happening. And there's a bunch of new members. I think 5 of the members on this panel were appointed with this week. So we're going to kind of see what's going on. But why don't we tune in a little bit for some of the first presentations. Today I put the agenda here on the screen, but it's all about the COVID vaccine. So we'll just listen in for a
Before
little
we do
bit and
that,
we'll comment. Yeah, go ahead.
Before we do that, Jake, just wanted to kind of make a general point that one of RFK's stated goals before becoming the head of HHS was to increase transparency around the vaccine process. And we talked before in a different recording about how firing people who are vetted through kind of a standard protocol and hiring people based with essentially no vetting is not transparency. It's the opposite of that. And since then, in the week before this important meeting happened, 5 new members were added to the panel, essentially stacking the panel with completely unvetted people with no understanding of how they joined the panel, what their background is in a lot of ways, and no real way to kind of say, are these people working in the best interests of the United States, the people of the United States, I should say, or are they placed there for some type of political agenda, advancing a political agenda? And our bias is that there's a strong suspicion that this was done kind of in the dark of night in order to advance a political agenda, and one that fundamentally I would say is anti-vaccine based on kind of the stated goals of a lot of the RFK Jr. Kind of crew, and so that's where we're at. I would say we're operating in an area of a lack of transparency and operating toward a vote that will impact millions of people.
Yeah, David, you're exactly right. And historically, this panel has been around for a long time. And when the original kind of COVID vaccines came out, there was a similar panel, but all those people on the panel had expertise in vaccines, and they weren't making these political statements prior to it. So I think we're all kind of a little bit nervous going into this meeting, not sure what's going to happen, what the official recommendations are. And I think, people in my family have already gotten the COVID vaccine this year. And I think this is going to kind of dictate is how many people are really going to get it based on these recommendations.
And just to kind of piggyback on not really knowing what's going on, I think it's worth drawing attention to something that happened yesterday during the vote, where one of the panel members didn't understand what they were even voting for, and so they chose to abstain. The panel was trying to push them to vote, but they said, I don't actually understand what we are voting for right now. I'm going to abstain from this vote. And what that says to me is that there is a major a lack of organization, a lack of clarity around what's happening, and a lack of professionalism in some capacity, because this has kind of been cobbled together last minute and feels like it's being kind of pushed through without much in the way of a proper vetting.
Yeah, that vote was amazing. I kind of watched that yesterday. It was about the hepatitis B vaccine, and a bunch of the panel members were very confused with the second part of the vote, which is whether or not they would fund these vaccines as part of the childhood vaccination program. So they decided to not change anything with the funding mechanisms, despite changing the actual recommendations, which was a little bit odd. And one member was so confused they just kind of abstained. Great. So I'm sure we'll have some fireworks today. So what we're going to do, just to kind of set the stage here, is we'll listen into some of the presentations kind of in an abbreviated format. And then I'd love to, David, get your opinion as things kind of come up. We'll kind of comment. And in the meantime, I'm going to post this on Blue Sky and see if we can get more than our 2 viewers that we have right now. But it should be a fun couple of hours here. All right. So
goals. So the immediate goals were very much focused on the current meeting.
So now we're listening into the actual feed
we're
here.
tasked with thinking about the recently authorized products and think about what populations and subgroups should be recommended what. And the options that we considered are either recommend, not recommend, or individual-based decision. And we're going to make a precise definition of what this is later today. We also felt that one of the things that we wanted to address with respect to this meeting is to really think about all the risks and uncertainties that we would like to suggest that should be communicated more consistently with patients, and in particular, potential changes to the vaccine information statement that the work group found that its current state is not reflective of the true risks and uncertainties. We also considered, and we have medium-term goals. We have an expansive terms of reference, and just for the record, the only debates that we had so far with the former leadership of the CDC were around the scope of the questions that we can ask. And we believe that ACIP, and as a result, the work group, should really be able to ask and consider any potential information or knowledge that is relevant to vaccine policies, vaccination policies. That's our charter, and we believe that we need to pursue that and really have 3 focus clusters that are assigned to workgroup members based on their expertise. And the goal of each cluster is to summarize all the available knowledge for the discussion in the workgroup and highlight important issues and knowledge gaps, and as a result, hopefully formulate policy options on broad vaccination-related issues for consideration by ACIP. That's kind of how we see the long-term goals of this workgroup. I want to say something about
pause? I want
values
to comment on that.
conduct.
Yeah, because I think one of the big challenges there, that sounds good on its face. And if you believe people are operating in good faith, it makes sense to include all available knowledge and all knowledge gaps and consider all knowledge gaps that might be present out in the field. However, the challenge is that there's so much vaccine misinformation and there's so much pseudoscience that goes into promoting that vaccine misinformation. And so if you're considering all knowledge, I mean, what does that mean? And I think it's important to kind of distinguish between established facts, established knowledge gaps versus pseudoscience and kind of throwing smoke in the air and trying to understand or trying to distinguish between what are real facts and what aren't. And what my big concern is that a vaccine panel of this importance and of this national standing, if it's done through a political lens as opposed to a health lens, they are much more susceptible to the inclusion of pseudoscience into their determination of facts. And I think that's just something that we need to really focus on. What is pseudoscience? What is good faith attempts at understanding vaccine policy implications and what is political agenda. And it's not easy to separate those, especially when you don't know who these folks are and when they just joined within the last week to comment on this panel. It's a way of confusing the issue and pushing through essentially propaganda from non-scientific based entities.
Yeah, also, like, look at this slide. They have safe and effective in quotes. One of the themes is the panel members hate this terminology, safe and effective. They were claiming that it's unscientific to say anything is safe or anything is effective. And just like as a doctor, thinking about even when we're prescribing antibiotics, right? Like, yes, there's some side effects, but we consider pretty much most of the things that are approved safe, and there's some threshold that it has to get to say it's safe. And same thing with effective. So this idea that every single decision has to be a personalized risk-benefit analysis is kind of strange. Like, it's not really how we practice medicine.
Yeah, ultimately, it's really challenging for even doctors to understand what is termed safe and effective. And we rely on a broad synthesis of the available data in order to make those claims or make those terms of in order to use those terms when we discuss these things with our patients. And it's impossible for parents who are, doing whatever they need to do to take care of their kids and staying busy with that, to be expected to synthesize the data, understand the literature, and kind of come up on their own with whether or not something is safe and effective. That's why they rely on doctors, and that's why doctors rely on well-vetted, nationally established guidelines, and we're moving away from that.
Yeah, it's quite remarkable.
So
let's listen back in for a little bit.
Language to talk about the issues related to vaccination. And in terms of how we are going to conduct the work group, when we conducted it, we believe strongly in debate with respect, and also with communicating the work group's members' diverse positions and opinions with maximum transparency. And you're gonna hear today 3 presentations of work group members. The first one will be by Professor Elderi and Professor Cooper-Wasser, and on some safety uncertainties of COVID-19 vaccines. The second one will be by Professor Carlton about genomic of vaccine-induced myocarditis. And just to speaking to the open debate.
Skip ahead to the first presentation here.
Go a lot faster.
And I will just say one thing, that Dr. Charlotte Cooper-Weiser, she's from Tufts University, not Tufts. And obviously it's a minor thing. It's a typo in their slide deck. But again, they misspelled the university where she works, which to me just speaks to a lack of professionalism and a lack of attention to detail, and the fact that this is kind of really rushed through. So I think there can be a lot of examples of that where you don't want to be nitpicky, but whenever we're doing scientific research or guideline promotion or policy implementation, we pay a lot of attention to details. And if they aren't even able to get the name of a university where one of the presenters comes from, right? What else are they missing? What else is being missed?
Can I have you review my slides before my next talk? You seem to have a good eye for that. But I completely agree. Like, this feels like it's thrown together because all the panel members half are appointed within the week. Some of the presentations that you'll hear, just for our audience, are by folks who have been at the CDC for a while, and they do have content experts, and then representatives from all the drug companies are actually going to speak. It's a little hard to follow exactly who is talking at any one time, but this next presentation kind of just update on the COVID-19 epi.
All right, good morning. My name is Dr. Arjun Srinivasan. I'm the Acting Chief Medical Officer for CDC's National Center for Immunization and Respiratory Diseases. I'll begin today with updates to COVID-19 epidemiology. I'll note that as yesterday, I am joined by subject matter experts on the line to respond to questions. And I will also note that I have been asked to move very fast, so buckle up. The data presented and discussed in this section will be data from the COVID-19 Associated Hospitalizations Surveillance Network, or COVIDNet. COVIDNet is one of 3 RESPNet platforms, in addition to RSVNet and FluServeNet, that collect data using similar methods and catchment areas on laboratory-confirmed COVID-19, RSV, and influenza-associated hospitalizations, respectively. It is a collaborative effort between CDC and state and local health departments who share data with CDC via cooperative agreements. COVIDNet is a population-based surveillance system that collects and reports data from more than 300 acute care hospitals in 185 counties across 13 states. The COVIDNet catchment area includes about 10% of the U.S. population. COVIDNet collects and reports 2 types of data. The first type of data are population-based rates of COVID-19 associated hospitalizations. These include all hospitalizations that meet the COVIDNet case definition of a laboratory-confirmed SARS-CoV-2 positive test among hospitalized residents of the COVIDNet catchment area. COVIDNet collects and reports some data for all cases, including age, sex, race, ethnicity, site, and test and admission dates. The second type of data describe clinical characteristics of hospitalized patients, including outcomes, underlying conditions, treatments received, and discharge diagnoses. These data are obtained through detailed medical chart reviews of an anonymized site and age stratified random sample of hospitalizations. When presented in reports or presentations, clinical analyses are limited to hospitalizations due to COVID-19, the definition of which will be presented later. The primary purpose of COVIDNet is to monitor laboratory-confirmed COVID-19 associated hospitalizations among children and adults and deliver these data to decision makers and the public in order to provide a broad and timely understanding of COVID-19 trends. COVID-19 associated hospitalization rates are updated weekly and are used to estimate and compare disease burden and respond to rising rates. Detailed clinical data, including underlying conditions, allows CDC to categorize hospitalizations that are due to COVID-19, better understand COVID-19 associated hospitalization trends and determine who is most at risk, track severity of illness, examine how many people hospitalized due to COVID-19 have underlying medical conditions, and provide insights into treatments used. When defining COVID-19 associated hospitalization in COVIDNet, a case is counted if the person lives in the defined COVIDNet catchment area and tests positive for SARS-CoV-2 using a laboratory-based molecular, antigen, or serology test within 14 days before or during hospitalization. This definition is used to monitor overall trends in hospitalizations. The surveillance definition is a simple approach that works across hundreds of hospitals and is available in near real time. Similar definitions are used to monitor hospitalizations for other pathogens like RSV and influenza in the US and worldwide. This approach was developed by infectious disease experts, and the surveillance definition has met the balance needs of accuracy, speed, and broad coverage over COVIDNet's 5-year existence. There has been sustained interest in determining whether hospitalizations among SARS-CoV-2 positive persons are with or for COVID-19 related illness. During the early pandemic with asymptomatic trends.
So I'm going to pause there for a second. David, what do you think about this whole debate that, like, what are people talking about when they say for versus with? I feel like this came up a lot early on in the pandemic when we were kind of doing case counts. So what's going on here?
Yeah, I mean, I do think it's a relevant point to bring up. I mean, I don't think that there's a hidden agenda with that, although the data can be used in different ways. People oftentimes will get, say somebody has cholecystitis, they have a gallbladder infection. They also happen to have COVID-19 at the same time, but they're coming in because they have a gallbladder infection. Well, that would be a hospitalization with COVID-19, not due to COVID-19. They're being admitted for a different reason. I would say that is in contrast to 2 different kinds of presentations. One where somebody actually has like COVID-19 pneumonia. They're sick with pneumonia, they have COVID in the lungs, and that's like your classic presentation. But another one is, for example, like COPD exacerbations or an asthma exacerbation. So you have COVID, your main reason for being admitted to the hospital is respiratory failure from COPD exacerbation. That COPD exacerbation is due to a COVID infection upstream. So I don't know how they're going to choose to do that. I think it can get very muddy if somebody has a heart attack, for example, because they have COVID-19 and their body's completely inflamed from it. I think
Yeah,
it's going to
I think
be
that's what's
a
always been
challenge.
very, when we talk about this, always been very hard to tease out, right? There's clearly some people test positive for COVID, and it's probably not why they were hospitalized. But because COVID affects pretty much every organ, including clots, like if a patient's there with a pulmonary embolism or a blood clot to the lung, and they test positive for COVID, it's very likely that COVID contributed to it. So I think it is an important distinction, but it can be used inappropriately, this kind of for or with. And back in 2020, we used to test every single patient who walked through the hospital door for COVID. We don't do that anymore. So I think that this distinction is less pertinent now. Let's kind of see how they use it. I'm not sure what they're going to say.
Vaccinations and high rates of illness, hospitals screened every patient when they arrived at the hospital. The screening likely identified hospitalizations among SARS-CoV-2 positive asymptomatic patients or persons with COVID-19 illness who were hospitalized for other reasons, like surgery or labor and delivery. As a result, COVIDNet implemented an algorithm to track cases with COVID-19 identified as the likely primary reason for admission, hereafter referred to as hospitalizations due to COVID-19, using chief complaint and history of present illness. Data for all current and previous surveillance periods back to March 2020 are posted monthly on COVIDNet's public dashboard. It is our understanding that this topic was of interest to the committee. Of note, while widespread
So see, that's actually very interesting. What he just said there is the committee asked for data on this for versus with. And this presentation, I think, is kind of saying, well, how do they determine it? And it seems like they have a fairly good algorithm that's been the same for the past 5 years.
Screening of every patient for COVID has largely stopped. COVIDNet continues to use the algorithm. Before going further, we should describe some of the factors to consider when defining hospitalizations due to COVID-19. Regardless of the focus, identifying a singular cause of hospitalization can be difficult for several reasons. A positive SARS-CoV-2 test can influence the decision to admit a patient who has comorbidities or other conditions. Additionally, the presence of comorbidities or other conditions can influence the decision to admit a SARS-CoV-2 positive patient. Many data elements extracted from the medical chart, including SARS-CoV-2 testing, treatment, discharge diagnosis codes, and other data elements can misclassify hospitalizations with respect to whether or not they are due to COVID-19. For example, ICD-10-CM codes in the US are designed for administrative and billing purposes, not surveillance, and may overcount or undercount cases. Additionally, the COVID-19 ICD code can be used just to indicate a positive SARS-CoV-2 test. COVIDNet uses a rigorous and standardized process to determine whether sampled hospitalizations.
Yeah, so this is kind of the algorithm, I guess, you're using. David, are you still there?
Yeah.
Your video turned off, but that's fine. Okay, yeah, so this looks pretty standard. I'm going to skip ahead to see what the kind of questions are about for this.
92% of hospitalizations using COVIDNet's reason for admission approach had a COVID-19 ICD-10-CM code or sepsis or respiratory-related diagnosis. COVID-19's reason for admission approach is more conservative than examining discharge diagnoses, and more importantly, can be completed in a timely manner. Given the similar findings, these results give us confidence that COVIDNet strikes the right balance.
How much farther back do you want to go?
Because just to where he said 92% of people who were admitted through COVIDNet for a diagnosis of due to COVID were correct, essentially. I just want to make sure that I'm understanding that correctly.
Yeah, it looks like, so I think this is the key slide.
In ICD-10 code or
that was basically 88% of, yeah, I think you're interpreting it correctly. Like it's somewhere between 85 or 88%, depending on exactly how they did it.
A respiratory discharge diagnosis
is
shown in the dark blue box on the left. And as shown in the red box on the left, 12% of cases had neither a COVID-19 ICD-10 code nor a sepsis or respiratory-related discharge diagnosis. Moving to the boxes on the right, this flowchart describes how COVIDNet defines hospitalizations due to COVID-19, applying the reason for admission algorithm to the same sampled hospitalizations. Of them, 85% had hospitalization due to COVID-19 based on reason for admission, as shown in the blue box on the right. Of those, 91% had either a COVID-19 ICD-10 code or a sepsis or respiratory diagnosis, the same criteria used in the flowchart on the left. Of the remaining 15% who had a non-COVID-19 reason for admission, shown in the red box on the right, 64% also had a COVID-19 ICD-10 diagnosis code. In summary, the two approaches to classify hospitalizations as being due to COVID include identifying COVID-19 as the likely reason for admission or identified COVID-19 related discharge diagnoses. These two methods show very strong agreement, with 88% of all hospitalizations having a COVID-19 ICD-10 code or sepsis or respiratory diagnosis, and 85% identified as having COVID-19 as likely primary reason for admission. 92% of hospitalizations using COVIDNet's reason for admission approach had a COVID-19 ICD-10 CM code or sepsis or respiratory-related diagnosis. COVID-19's reason for admission approach is more conservative than examining discharge diagnoses, and more importantly, can be completed in a timely manner. Given the similar findings, these results give us confidence that COVIDNet strikes the right balance in terms of timeliness, accuracy, and representativeness of the population. This figure shows the rates of COVID-19 associated hospitalizations per 100,000 population by age group. These are cumulative rates and represent the cumulative risk of hospitalization by age group for the 12-month period of October 2024 through September 2025. As a reminder, these rates are based on the surveillance standard of a positive SARS-CoV-2 test among hospitalized residents of the surveillance catchment area. The cumulative rates for hospitalizations are highest among adults 65 to 74 and 75 years and older, as well as among infants less than 6 months of age. Unlike older adults, there has never been an approved vaccine products for infants less than 6 months, and the immunity to reduce the risk of hospitalization would need to be provided through maternal vaccination. This figure shows the percent of hospitalizations due to COVID-19 that resulted in severe in-hospital outcomes by age group, including admission to the intensive care unit or ICU in tan and in-hospital death in red. A significant proportion of adults hospitalized due to COVID-19 experienced severe outcomes, with 15% of adults having.
So that slide before where they show the infants, so infants less than 6 months of age rely on the maternal vaccination or prior immunity to provide protection. So one of the greatest risk groups, the less than 6 months of age, that group is actually kind of a little bit more protected from vaccinations in that age group that says 27, which is when a mother would be pregnant when they're in 18 to 49 years of age. So it's not a straightforward one-to-one, but importantly, one of the kind of least affected groups, people aged 18 to 49, are also the group that's most available to protect one of the most affected groups, the infants less than 6 months of age. And so I just think it's worth highlighting that point, because without those vaccinations, those infants would not have any sort of protection.
Yeah, and like the science behind that's very clear. The mom makes antibodies cross the placenta, baby gets antibodies. If the mom's breastfeeding, there may be some antibody transmission that way as well. But you're right, like besides the greater than 75 years old, less than 6 months is a dangerous time to get these respiratory viruses. I mean, it's worse than if you're 74. So exactly right, the moms need to get vaccinated. And the other thing that none of this data that I don't think they're going to talk about has anything to do with like reducing transmission. So you can also imagine, if the mom is vaccinated, they're probably also less likely to transmit to their family. But yeah, that's a great point. I'm kind of, if it's okay with you, I was going to maybe skip ahead a little bit here, just because there's a lot that they're covering, and it's
19 hospitalization by age group, with a focus on those less than 75. The rates of hospitalizations among infants ages less than 6 months remain close to those among adults ages 65 to 74 years throughout the season. The rates have diverged in recent weeks, with rates increasing among infants at a faster slope compared to adults 65 to 74, with current cumulative rates of 223 and 194 per 100,000 respectively. The cumulative rates during this period among infants less than 6 months are 14% higher than adults aged 65 to 74 years. The inset figure in the red box includes these same rates in addition to adults ages 75 years and older, indicated by the orange line. As background, this analysis on chronic conditions is an update to a peer-reviewed manuscript published in 2021. The results of that analysis informed the infographic pictured here, which summarizes the relative risk for hospitalization among persons with the specified conditions to those without. The data sources for this analysis were threefold and include COVIDNet data on the number of hospitalizations due to COVID-19 from October 2022 through September 23. Data on the prevalence of chronic conditions were from the Behavioral Risk Factors Surveillance System, or BRFSS, the largest continually conducted health survey system in the world, with hundreds of thousands of interviews among community-dwelling U.S. adults administered each year. Population data from the U.S. Census were provided by the National Center for Health Statistics. The methodology used for the analysis is complex, but in short, COVIDNet was used to obtain weighted counts of persons hospitalized due to COVID-19 with and without underlying conditions. COVIDNet data were limited to hospitalizations with COVID-19 as likely primary reason for admission, as previously described, and limited to community-dwelling adults, as BRFSS is only administered to community-dwelling adults aged 18 years and older. Weighted counts of community-dwelling adults with and without chronic diseases of interest in participating states were calculated using BRFSS data. Using state populations and statistical modeling, adjusted rate ratios of hospitalization rates with versus without chronic conditions were calculated. The chronic conditions examined were limited to those conditions included as part of the BRFSS interview and are listed here.
It's something that every American has.
This figure shows the prevalence of chronic conditions examined among adults admitted for COVID-19 in blue.
I mean, there's just so many here that is just so prevalent, right? Look at that prevalence, 30+% of people who are admitted have diabetes. It's kind of crazy.
Yeah.
This chart shows the rate ratios of chronic conditions comparing adults hospitalized due to COVID-19 with the condition to those without by age group. Among adults, most chronic conditions examined increased the risk of being hospitalized due to COVID-19. The risk conferred by several conditions appeared to decline with age, including coronary artery disease, diabetes, and obesity. This might be a consequence of an inability to adjust for comorbidities in the models or low population prevalence of some conditions in some age groups. For example, severe obesity is uncommon among adults aged 75 years and older, and COPD is uncommon among adults younger than 50 years of age. Additionally, this analysis shows risk for hospitalization due to COVID-19 increases with the
So I think what's super important about this is that, you know, the kind of vibes of vaccine is that, as we've discussed in the past, is like, well, we don't know if they work, but look at how much more likely people are to be admitted to the hospital if they have some of these chronic conditions. And there's probably a lot of people out there that have these chronic conditions and don't realize that their risk is really so much higher. So like 6 times higher if you have 3 chronic conditions. This is gonna be interesting discussion when we talk about what the panel's going to approve in terms of the vaccine utilization.
This analysis has many strengths. The data are gathered from a robust COVID-19 hospitalization surveillance system. This allows us to compare underlying conditions using state-level prevalence data and to examine how specific underlying conditions, the presence of multiple conditions, and age groups contribute as risk factors for COVID hospitalization. That said, there are limitations. Results are still preliminary and remain under review. As previously noted, this analysis is limited to community-dwelling adults to align with the population from which we have BRFSS data on chronic conditions. The risk for hospitalization due to COVID-19 among children or among non-community-dwelling adults, like those who live in long-term care settings, could not be examined and might be different from those presented. Some underlying conditions tend to co-occur, such as diabetes and chronic kidney disease. Adjustments for some comorbidities, such as adjusting for chronic kidney disease among persons with diabetes, could not be made due to sparse data, especially in younger age groups. Additionally, this analysis was not able to look at differences in rate ratios across outcomes, such as ICU admission or race and ethnicity categories, due to sparse data. And I don't know if we want to pause here for questions, Martin, or move, or Rex, sorry, do you want to move on to the next presentations?
Yeah, please move on to the next presentation.
Can we have the next presentation, please?
I object, Martin. I've got some really concrete questions I'd like to ask. Could I have permission?
Are you allowed to object to seeing the next presentation?
Yeah, I like it.
That was very funny. All right, let's see what
I'm into it.
his questions are.
I like the drama.
Please, Dr. Malone.
So as I understand it, and this relates to information that was presented by the CDC to the subgroup, help me to understand, there's significant overlap and challenge in the clinical diagnosis of COVID-19 as opposed to other, let's call them influenza-like illnesses. Is that true or false?
Meaning that the symptoms of COVID-19 overlap with symptoms for other respiratory infections.
Almost completely.
I would say that's true.
Okay, thank you. Number two, when I queried the CDC representative on the specificity and sensitivity of the testing being used, which is the other key leg of your whole data set, what she told me was sensitivity and specificity in this context were academic. Now, as somebody trained in pathology, who taught pathology for years, I object to that. My point is, it's lovely that you created all this data, but the two underlying theses that underpin all your data are tenuous. And in the case of the diagnostic testing, as has been widely noted, the diagnostic testing for COVID has had significant problems with specificity and sensitivity.
Okay, this is just not true what this guy is saying. I'm not sure
That's
who's talking.
not either.
Can you
That-
hear me?
Yeah, that's crazy.
Crazy. So
It's
I think for people who aren't familiar with this data and literature and use these tests, it may sound reasonable. But David, like, what is the testing currently for COVID that we use?
Yeah, I mean, it's a PCR-based test, so it's a quantitative, typically PCR-based test. Well, I shouldn't say that. It's qualitative, but they're different thresholds you can use to choose what a positive is. But it's a PCR-based test where they go in and they swab the nose, or in the case of somebody's intubated, they can get this from the lungs, and they'll run a PCR on it. And if that COVID DNA is not, or sorry, it's actually RNA, but if the COVID nucleic acid, the presence of the COVID virus is not there, the test, I've never heard, it's very, well, that's not true. It's very rare that you have a false positive, which would be the specificity.
Yeah,
And the
yeah,
sensitivity,
exactly, David. Like, if you have the flu and then you do a test, you're not finding COVID RNA there. So I think what this guy's implying is that that other influenza-like illnesses like flu and RSV are being misdiagnosed as COVID. But the specificity is nearly 100%. And when we say that, we mean the lab specificity. So actually finding the DNA or the RNA from the PCR test. If you find the COVID RNA, it's there. It's not like just magically appearing in the sample. The one true part that you mentioned, though, is that, right, if you had COVID a week ago and then you get tested this week, the PCR is so sensitive, meaning it can detect small amounts, you might still test positive. So there's a little bit of truth that if you're recovering from COVID or you had COVID, you still might test positive for it. And then the sensitivity, right, is kind of if you have the disease, what's the chance that the test is going to pick it up? And with the PCR-based testing that we do in hospitals, it's very high. So I think the number, if you were going to look in the literature, it's definitely over 90%. I would bet it's closer to 99% in terms
yeah,
of specificity and sensitivity, with the caveats about the when you're actually testing versus when the patient's symptoms started. So I think he's using all these words, and it's just not making sense for people who deal in this. Very weird comment.
And that's not factored into the model. Is that true or false?
Let me ask one of the subject matter experts to comment on sensitivity and specificity of the tests used in the model. Thank you.
This is the NCIRD SME room. The tests used in COVIDnet are the FDA-approved tests that are performed in hospitals and medical clinics across the country. We do not perform testing as part of the COVIDnet surveillance. Those are all clinically tests that are done at the clinical discretion of the provider seeing the patients.
Right. So what you're admitting or acknowledging is that all those tests have issues with sensitivity and specificity that will affect the interpretation of these data. True?
Hi, any test that is performed clinically has sensitivity and specificity values. These are FDA-approved tests that are used to identify patients who test positive for SARS-CoV-2.
But if they're only 80% specific, therefore as one example, your underlying thesis about what is a COVID case or not a COVID case inherits a similar level of ambiguity. True or false?
This is Natalie Thornburg, Lab SME and NCIRD. FDA has, and I'm not speaking for FDA, but FDA, all of the tests that have been used in COVIDnet, again, have been received FDA approval through CDHR, and they have baseline specificity and sensitivity requirements, and the specificity has to be above 90%, I believe, and sensitivity similar.
I actually don't like those answers from the experts, to be completely honest. Right? Like, we know the sensitivity and specificity of these tests. We know the specificity is 99%. They should just say that. The sensitivity depends when you're testing the patient in relation to the illness and where the sample's coming from, but also mid to high 90s. So very strange. Very early in the pandemic, as David will remember, we used to do 2 tests, right? The idea is you do multiple tests, you increase the sensitivity, but we don't need to do that anymore because we've realized the testing is so good.
I think the other point that's worth mentioning is that the baseline requirements are 90% in order for it to get FDA approval. That doesn't mean that that's the actual test characteristics. They're much higher, but the requirement for approval is 90%, but the actual performance characteristics are above that.
Yeah, that's a good point.
Thank you.
Dr. Srinivasan has actually 3 parts to his presentation. So the idea is to let him do all 3 parts before we have a question and answer. So if you have question and answer, we are noting that on the list here, and we will do that in the order
Jake,
as
I
you
gotta
request
run.
them, but we will.
All right, David. Well, thanks for joining during our first live broadcast.
Yeah, let's meet back again shortly. I think that there's going to be more and more. I mean, that question was clearly designed to undercut the entire data set, and it's interesting that they're using essentially kind of false pretenses as far as the numbers go. He said 80%. That's like wildly low for a viral test. Like that's so far below what we actually use clinically that it's you can see they're starting to throw that smoke in the air already, or at least some of these folks are. So how much of these are good faith questions ahead is going to remain to be seen. But we'll reconnect in a bit and go back over some of this.
Yeah, that sounds good. So are you back later today, or are you gonna?
Yeah, I'll try and make it. I'm busy, but I'll try and make it work at like 2 to 2. What'd you say? 2:30?
Yeah, the votes are supposed to happen at 2:15. But if you're back around 2:30, we can kind of see what they're doing.
Okay, that sounds perfect.
We'll take a little pause in the live stream, and then we'll reconvene in about an hour or so when David is back. All right. Bye, David. Thanks, everybody. That was fun. Fun little practice at our first live stream.
Yeah, I'm sure there'll be more ahead.
We had 2 concurrent viewers at one point.
Woo, getting big.
All right, I'm going to end the stream.
All right.